Hello and welcome to another live broadcast with MedStar Health. My name is Michelle Bowman Carter, and today we're talking all about heart disease prevention. We're kicking off American Heart Month, and I am joined today by several of our cardiologists. Dr. Bolanle Akinyele, Dr. Mehdi Gishlagi, Dr. Stuart Gould, and Dr. Reginald Robinson. So if you'd like to learn more about reducing your risk for heart disease, the best prevention methods, and the signs and symptoms that you shouldn't ignore, stick around, share this broadcast with your friends, give us a like to let us know that you're watching, and share this broadcast with your friends, and ask any questions that you have along the way. We're going to take some time to answer those as well. All right, so welcome and thank you, doctors, for joining us today. Thank you for your time. So let's dive into our questions. I'm going to start with Dr. Akinyele. So let's start with the basics and knowing your numbers. What are the most important numbers that patients should focus on?
Thank you, Ms. Shawn, and thank you everyone for coming today. I'd like to broaden that question a little bit. Rather than focusing on just the numbers, let's focus on all the things that we focus on to help you prevent heart disease. I think about it as the Jackson 5 ABCs, which was coined by one of my mentors at Hopkins. A stands for assessing your risk. That's what we as physicians do when you come to us. We get a history, both your personal and family history. We get a sense of your risk factors. And using some clinical tools, we get a sense of how high or low your risk for heart disease is and how aggressive we need to be in addressing those risk factors. B stands for blood pressure and BMI. How high is your blood pressure and what are the optimal goals for your blood pressure for us to be able to reduce your risk for heart disease? The other B stands for BMI, known as your body mass index. It's a calculation that we use to figure out what weight category you're in. Are you a healthy weight, overweight, or obese? That helps determine what kind of risk of heart disease that you can have in the future. C stands for cholesterol and cigarette smoking. What are your cholesterol numbers? Those are important numbers to know, especially a number we call LDL, which is commonly known as your bad cholesterol. That's a very important number to know as it increases your risk for heart disease. The other thing is, do you smoke? That is one of the number one preventable reasons that people have heart disease. So if you're a current smoker, the biggest advice we can give you is to stop smoking. D talks about diabetes and your diet. Diabetes is how your body handles the blood sugar. Are your blood sugars level high? That can increase your risk for having heart disease. What is your diet like? Does your diet increase your risk for having blood pressure problems, weight problems, diabetes, high cholesterol? Those things need to be focused on to reduce your risk for having heart disease. E stands for exercise. How much exercise are you getting in a week? What kind of exercise are you getting and how often are you getting that exercise? That's very important in reducing your risk. And lastly, we think about family history. What is your family history of heart disease? Are there young people in your family are there people in your family that get heart disease at a young age or die at a young age from heart disease? Those are important factors to know, and a lot of the list of the things that we focus on to help you prevent heart disease. Thank you.
Thank you very much, Dr. Akinyele. I think that's a really good point to remember the important numbers and factors, the A, B, C, D, E, and F of heart disease prevention. So thank you very much. All right, I want to talk about one of those letters, the C word, cholesterol, and ask you, Dr. Gishlagi, could you explain cholesterol numbers and what is considered good and bad cholesterol?
Sure. Happy Heart Health Month, first of all, and thank you for having me on Facebook Live. So as we know, cholesterol levels actually play a role in heart disease and heart conditions. We know that that's a kind of fat-like substance that's found in all the cells in the body. Also, the liver makes some cholesterol for the body to just work properly. But if you have too much cholesterol in the blood level, it may increases, the risk of heart disease, especially coronary artery disease. So cholesterol levels can be measured by blood test, as we know, and you need to be fast, not eat or drink anything at least for 9 to 12 hours prior to the test. So the cholesterol level is measured in milligram per deciliter. So when we have the test done, so it gives us some idea about the total cholesterol, which is a measure of the total amount of cholesterol in the blood level, including bad cholesterol or LDL cholesterol, as well as good cholesterol or HDL cholesterol. Bad cholesterol is the main source of cholesterol buildup and blockage in the heart arteries and other arteries too. However, good cholesterol helps remove bad cholesterol, from the arteries. Reaching to healthy levels of cholesterols. So it differs based on the age and gender. So anyone age 19 or younger, they should have a total cholesterol of less than 170 milligram per deciliter. The bad cholesterol or LDL cholesterol should be less than 100 milligram per deciliter. And for good cholesterol or HDL cholesterol, for people younger than 19 years old, should be more than 45 milligram per deciliter. For actually men age 20 or older, the total cholesterol should be between 125 and 200 milligram per deciliter. LDL cholesterol, similar, should be less than 100 milligram per deciliter. HDL cholesterol or good cholesterol should be 40 or more. For women, actually age 20 or older, numbers are similar except for good cholesterol. It's recommended that the good cholesterol, or it's a good idea that the good cholesterol or HDL cholesterol should be more than 50 or more than 50 to be protective for heart disease. So these are the numbers that we should remember, especially the bad cholesterol that we always emphasize on should be always less than 100 milligram per deciliter. The good cholesterol, actually genetic or genes play a role in good cholesterol, and we cannot manipulate that that much with medicines or diet. However, we can just reduce your total cholesterol as well as bad cholesterol and minimize and reduce our risk factors. So there are two main ways that we can reduce total cholesterol. One is through heart healthy lifestyle changes. And second one is drug treatment. Heart healthy lifestyle changes, as Dr. Akinele mentioned, that heart healthy eating plan is important. So heart healthy eating plans limits the amount of saturated and trans fats that you eat. These kind of diets that we recommend as cardiologists are a Mediterranean diet, which is well recommended, and also DASH eating plan, which is also well recommended and studied by American College of Cardiology and American Heart Association. In addition to eating heart healthy diet, weight management is also important. If you're overweight, losing some weight may help lower down your bad cholesterol or LDL cholesterol. Physical activity and exercise matters. Everyone should get regular exercise and physical activity. Moderate intensity exercise, at least 30 minutes on most, but not all days, is recommended. Stress and managing stress is also important. Research has shown that chronic stress can sometimes raise your bad cholesterol level and may lower down your good cholesterol level. So managing daily stress is also important. And finally, quitting smoking is also important. Quitting smoking may raise your good cholesterol or HDL cholesterol. And HDL cholesterol, however, can remove bad cholesterol from your arteries. So that's important to, quit smoking. Finally, if all of these heart healthy lifestyle changes do not work alone, so you may need some medicines to lower down your cholesterol. So there are different medicines out there, including statins, and they can work from different ways. They may have some different side effects. It's a good idea to talk with your healthcare provider to find the right one for you. Once you're on medicine, so you should consider that you should continue lifestyle changes at the same time that you are taking medicine.
So thank you very much, Dr. Gishlagi.
You're welcome.
Thank you. I'd like to talk to you, Dr. Gould, about blood pressure now. Why is it important to measure your blood pressure? And also, what are the guidelines for having a healthy blood pressure?
Well, thank you. I appreciate the invite and being on this panel with such esteemed other cardiologists. I'm Dr. Stuart Gould. I work in Albany, Maryland, Montgomery Medical Center. My office is here in Albany, and the hospital I work out of here is Albany as well. And I also practice at outpatient MedStar cardiology or primary care doctor's offices in Gaithersburg and Leisure World as well. So, and I'd be happy to get to the blood pressure discussion. I just want to add on to what Dr. Gishlagi already mentioned about cholesterol. When you see a primary care physician or cardiologist, as we mentioned before, that, it's all about risk assessment and things. So in addition to getting your cholesterol levels checked, a lot of times cardiologists or primary care doctors may order, well, one thing they'll probably do is do a calculation of your 10-year cardiovascular risk based on age, blood pressure, like I said, which I'll get to, gender, sex, things like that, and your cholesterol numbers. So it is important not just to worry about numbers, and I'm sure you'll hear of us a lot of talk some about numbers, but also trying to evaluate the overall assessment of your other risk factors as well. So, and then sometimes what cardiologists will also do is based on your family history, if there's a strong family history of heart disease, may get something like a coronary calcium score. So there's a lot of different tools that physicians can use to help assess your risk based on the things we'll be talking about in terms of blood pressure and cholesterol. And then, getting back to the blood pressure issue, I always explain high blood pressure or hypertension as a silent killer. Most people don't know they have high blood pressure unless they're checking it either at home or their doctor's office. And so since most people are asymptomatic, that's why it's important to get screened on a regular basis with your provider, or there's so many devices at home that people can use to check their blood pressure. And, I also explained that high blood pressure sort of as a chronic issue. Over time, more than half of Americans in the United States over age 50 will have high blood pressure. So, and fortunately, people living longer, we treat more diseases, diagnose diseases earlier, and intervene earlier as well. So as people get older, it becomes much more prevalent. So when you're checking blood pressure, the things you want to do is make sure arm cuffs are more accurate than these wrist cuffs that people have. You want to be sitting comfortably, resting for about 5 minutes. If you can, have your arm resting comfortably on a table or something, ideally close to your heart level, and then check your blood pressure. If you've just exercised, did some other activity that's been stressing you physically or emotionally, probably worthwhile maybe even waiting longer, even up to a half hour, to check your blood pressure, because we want to see what your blood pressure is really at a resting state. And sometimes it requires to check your blood pressure on multiple occasions, not just one occasion. In fact, usually when we diagnose high blood pressure, we like to see maybe 1 or 2 office visits with the blood pressure if it's elevated, and even encourage people to check it at home, because sometimes there's a thing called white coat hypertension where people's blood pressure may be high in the office but may be normal at home. And sometimes we see the opposite, which is masked hypertension, where people's blood pressure is high at home and maybe closer to normal in the office. So we need to see over time what the blood pressure readings are. And typically we say anything over systolic of 130 or over systolic of 80 is where we discuss about really intervening, whether it's lifestyle changes or maybe even pharmacologic treatment with medications. As mentioned before, lifestyle changes like exercise, weight loss are all very important to help manage your blood pressure. Watching the salt in your diet, really you shouldn't have more than 2 grams of salt a day, especially if you have high blood pressure. Ideally, if you can have less than that, it would be even better. But even lifestyle changes, although important, still only will lower your blood pressure, maybe 10 millimeters of mercury. So it's our pharmacologic treatment or the medications that really have the biggest impact in terms of treating blood pressure. And fortunately, there's so many different medications out there, have different mechanisms of action to really affect blood pressure and help. And usually, especially people have really bad high blood pressure, a lot of people need to be on multiple medications, more than one. So it's important that you're seeing your doctor, having that evaluated, evaluating your other risk factors too, because if you're diabetic, We may choose a certain blood pressure medication. If you have some other disease like heart disease, heart failure, coronary artery disease, we may select a different blood pressure medication. So there's a lot of different factors that go into determining which medication we'll use. And over time, if we can get the systolic blood pressure under 120, that'd be great. That's really our real goal there. And then with regards to low blood pressure, I always tell people, know your blood pressure is too low if you're passing out, truthfully. So obviously we don't want people passing out. We got to be careful when we're managing people's blood pressures. So there's no set number there, but if you ever feel like lightheaded, dizzy, feeling like you may pass out, obviously that's reason to talk to your physician about that, especially if you're on blood pressure medications.
Thank you very much, Dr. Gould. I want to turn over to Dr. Robinson. Let's talk about BMI. Could you first explain what is BMI and what does that number mean? What does that entail, and what is a good target for BMI?
So you did have to put me on after all of these wonderful doctors to follow up on all the discussion. So my name is Reginald Robinson. I've been a cardiologist with MedStar Health for over 20 years. I practice out of the Washington Hospital Center, as well as the Hospital Center office and our Bowie office. And I like to say thank you for helping us kick off American Heart Month. I'm the board president of the Eastern States Board of the American Heart Association. So thank you for doing that as well. Just wanted to backtrack on the cholesterol and some of the things that I help my patients to try to remember. The cholesterol value, you think about L for lousy. So that's your lousy number. And they sort of get that. H for happy. And I just had to come up with something for the triglyceride. I just said T for trashy. That's your fatty cholesterol. Right. So you can easily remember the lousy one, the happy one, and the trashy cholesterol values. When you think about hypertension, as Dr. Gould said, it's a silent killer. It's the leading cause of congestive heart failure in the African-American population. So we need to really push that forward, that hypertension is just not something that's sitting out there. It's actually causing damage from head to toe. And the way I describe that is think of you doing the bench press. So that top number is like you're doing the bench press this way, your systolic blood pressure. When you bring the dumbbell down, you're trying to relax the muscle. But imagine if someone's still pushing down on it, that's your diastolic number. So your heart's pumping 10 to 20,000 times a day. So what happens when you're lifting weights? Your muscle gets thicker. It has to get thicker to compensate for lifting heavier weights. That's the same thing that happens with your heart when you're under a bunch of stress from hypertension. And over time, as it gets thicker, you lead to the first stage of heart failure where it gets stiff. And then if you keep on going through that stage, it's like a balloon. If you keep stretching the elasticity out of that balloon, it gets weaker and doesn't have much kickback. So you're into what we call the systolic phase of congestive heart failure, where the heart's weaker. But that's not all doom and gloom. And we'll talk about that a little later, that there are things that we can do to help prevent that. Getting back to BMI, Dr. Akinyele talked about BMI earlier. And when we look at BMI, you have to really put it into context based on gender, ethnicity. If we look at a BMI of a running back in NFL, we would consider that person overweight or obese because muscle mass is a lot heavier than fatty tissue. And to calculate BMI, you're looking at weight in kilograms, which is 2.2 pounds per kilogram, over your height in meters squared. So that's the formula that they use. Someone with the quote BMI between 25 and 29, they're considered overweight. And when it's over 30, it's obese. And we don't really need to look at that a lot of times. We can see the patients coming into our office and know who's in trouble. 2/3 of Americans are overweight and obese. And what comes with that are a multitude of medical problems, not only cardiovascular issues from hypertension, include sleep apnea in there, diabetes, congestive heart failure, different types of cancers can be related to this inflammatory process of obesity. Looking at the waist to hip circumference ratio, that's another measure. It's an old measure, but you can look at how big your waist is compared to your hips. They use 35 inches in women and 40 inches in men. So that's another variable. You would see back in the day, you look at the shape of a person, a pear shape, an apple shape. If you have more fatty tissue in the midsection, that fat is not just sitting there, as I explained to my patient, it's actually active tissue, making your body responsive or not responsive to your own insulin. So it makes you more insulin resistant. increasing your risk of becoming a diabetic. And as everyone else said earlier, the multiple things that we can do to try to decrease that obesity and help to impact some of those chronic conditions that come along with that.
Thank you very much, Dr. Robinson. At this time, I'd like to pause and welcome our viewers again. If you're just joining us now, thank you very much for tuning in. Today, in honor of American Heart Month, we're talking all about heart disease prevention, how to reduce your risk, the signs and symptoms to look out for, and what you shouldn't ignore. I'm joined by our cardiologist, Dr. Bolanle Akinyele, Dr. Mehdi Gishlagi, Dr. Stuart Gould, and Dr. Reginald Robinson. We have more to talk about, so keep watching, share this broadcast with your friends, and ask us your questions in the comments below. We're going to take some time to answer those. And speaking of questions, we have a few from our audience. So I wanted to address a few of those before we move forward. The first question I have is from Delara, who asks, are there any supplements or sources for good cholesterol?
So I think that's a question for me. So in the past, there was a trial that said maybe niacin, which is a kind of medicine, can raise the good cholesterol. But unfortunately, a few strong trials later on showed that there is no good impact from niacin. So as we speak right now, there is no medicine available to raise good cholesterol. And gene plays a role in the number of good cholesterol. Unfortunately, it seems that at this time, to me, and correct me, the panel, we don't have a medicine. And if you're bound to a lower good cholesterol level by your genes, so there's no way right now that we can just raise it further. But at least keeping the bad cholesterol at target and lowering the bad cholesterol level, at least you have the opportunity, to reduce your risk further. But having said that, there's no medicines, and diet-wise, there's no strong data or study that shows like a kind of diet or vegetables or fruits can raise HDL cholesterol at this time. So we don't have a strong data, but there's some room for more studies to be done.
Thank you, Dr. Gishlagi.
Yeah, I want to piggyback on that, moving to the triglycerides. And I always tell people that anything that goes in your mouth is a medicine. Just because Cousin Joe had it and he got cured from it doesn't necessarily mean that it's standardized treatment. And so I wanted to lead with that. All medicines are medicines, whether they're natural supplements. And take, for example, red yeast rice extract. That was the first statin. That's where we found simvastatin. And that's a natural supplement. But if you get the wrong version of that, you can go into liver failure. That's one thing that the nutraceutical companies, they're not standardized. So if you get one particular red yeast rice extract where that has too much high monocolon, you have to read all the ingredients in it. It can cause liver damage. So there is some pure forms that may help a little bit with the LDL. When you think about the T for trashy cholesterol or triglycerides, you tend to have to take higher doses of omega-3 or actual EPA and DHA, which are the active ingredients. So really understanding what you're getting if you're trying to go out and quote do supplements, because not all fish oils are the same. It may say 1,000 milligrams, but it may only have 100 milligrams of the active ingredients. So you may have to take 9 tablets a day of something like that. So really, if anyone's giving you something, make sure they give you the data supporting it. Flaxseed is a plant-based omega-3 that's less concentrated than the animal-based or fish-based. But there's always cold water fish that have higher concentrations of natural omega-3 in it that you can focus on, like salmon, Arctic char, sardines, those kind of things that have higher good fats.
Well, thank you very much, Dr. Robinson. I want to also, I think you brought up a good point about the supplements, and just want to reiterate the importance of anytime that someone suggests taking a supplement, always consult your doctor and your primary care provider and your cardiologist as well, just to make sure that you're on the right track and want to be aware of any possible side effects as well. So thank you both, Dr. Gishlagi and Dr. Robinson. I have another question from Christine, who is asking, what are good cholesterol numbers for women over 65?
So the good cholesterol for women at over 65 should be 50 or more. So that's a number that for women age 20 or older is, recommended to be a little bit more than, men. For men is 40 or more milligram per deciliter. For women to be more protective, it's should be like 50 milligram per deciliter or more.
And I just wanted to further elaborate on that in terms of numbers. Everyone gets so fixated on numbers, and numbers do mean things, but once again, you have to put in the context of that individual's risk. And, especially women, once again, in their 60s, most men in their 60s, have higher risk of heart disease, and women, once again, in their 60s, start catching up to men in terms of risk of heart disease. So it goes beyond the numbers. Numbers are important, but that's why it's important to meet with your physician, talk to them about your other risk factors in addition to those numbers.
Good point. Good point. Thank you, Dr. Gould. I want to get back to some of our questions. I'll get back to the audience questions a little later, but thank you very much for sharing those with us and keep them coming. So at this time, I'd like to talk about diet with Dr. Robinson. So for heart disease prevention, what types of foods are best to eat and which ones should a patient limit or avoid altogether?
If I had that, I would have I can start with the basics.
Okay, give me the basics.
So Dr. Gishlagi mentioned the Mediterranean diet, which tends to be diet heavy in darker vegetables, plant-based. Mediterranean, of course, olive oil, extra virgin olive oil. And if you look at all the diets, I don't pick a particular diet when patients ask me, which diet should I use? The thing that they have in common, whether it's the keto diet, the South Peak diet, the Atkins diet, is eliminating a lot of the simple carbs in your diet, right? So those are all the white things that can convert into sugars pretty quickly, and we store them as fats in the form of our triglycerides. So white bread, white rice, white pasta, stuff made out of flour, certainly sodas. Some juices have just as much sugar as a can of soda. So if you're diabetic and you're sipping your grape juice and apple juice thinking that it's from an apple or grapes, that it's better for you, that can have just as much sugar as a can of soda many times. So you have to actually start looking at the numbers and the amount of sugar and carbs, well, more sugar, grams of sugar, when you look at that. So when you think about complex carb, those are the more fibrous things. So a sweet potato is better than a white potato when you look at the starchy or the root vegetables.
Okay.
The more color, the better. I always like to say that the more color, the better. I tell my patients if they can try, I meet them where they are. If you go and tell a patient that they need to become a vegetarian, you've lost them already, right? Because most people won't do that. But most people can do 3 days or 4 days of plant-based only. And then the other 3 days of fish. You can make a compromise so that they can start doing that. Imagine that whatever you're going to stick that meat on and surrounded by these other things, just take the meat out of the middle. And those are your 3 days of plant-based and minimizing the starch. The one white food that I would say it's okay is cauliflower.
I like cauliflower.
Yeah. And, if you have hypertension, there's so many people getting into these plant-based burgers now. But I say, how much sodium is in that? Well, no, it's healthy for me. That's a ton of sodium in many of those plant-based. If it comes in a box, can, or a package, it's probably too much for you if you have hypertension. So limiting, if you do have a history of hypertension, I would decrease it down to less than 1,500 milligrams of sodium a day. That's about a tablespoon of sodium. So that's how food stays so long in the freezer, because it's packed and condensed with sodium. If you're getting say deli meat, unless it says fresh cut deli meats will last forever nowadays. Back in the day when I was growing up, deli meat would go bad pretty quickly, but now you can have deli meat in your refrigerator for like a month Why is that? Because it's packed in sodium to help keep that, keep it around for you. So keep it simple.
Keep it
Minimize the white foods in the diet. The more color, the better. Take you 3 or 4 days of your plant-based.
I like that advice. Something that I can take away with me, because I do like my French fries and chips, but I'll keep that in mind next time I cook dinner. So
I like them too. Everything in moderation.
Exactly. Thank you very much, Dr. Robinson. Dr. Gould, let's talk about exercise. I think diet and exercise go hand in hand. So I think that's a good segue to some of my questions here. So what is the recommended physical activity needed to make a difference for being healthy?
Well, that's a great question. And, unfortunately, our society is becoming more sedentary, especially during this pandemic. People not going out as much, not commuting to work, not walking to work, sitting in front of the computers doing Zoom, things like this. So as we become more sedentary, that's more troublesome. In fact, the more sedentary you are, there's 20% increase in mortality the more sedentary you are. So you got to get up and move. Bottom line, as Nike says, just do it. You got to exercise. In terms of recommendations of how much, they say 150 minutes a week is what really is recommended. And if you want to lose weight, it needs to be 300 minutes a week. So, you have to always tell people, especially when you talk about losing weight, it's a simple formula: less in, more out, right? Burn more calories, consume less calories, So, diets, you can talk about all the diets you want, but if you're not exercising, not burning those calories, it's not going to make a difference. And exercise is not just important. It's obviously very important for the heart. It allows us as clinicians to figure out, hey, you exercise, you feel good. I feel more confident that your heart is healthy. If you're exercising and not feeling well, then yes, you're having chest pain, shortness of breath while you're exercising. That's when you need to go see your doctor or go see your cardiologist. But exercise is key, and it's also good for your overall well-being in terms of weight control, and also for your mind too, right? Today, there's so much depression, anxiety, especially during the pandemic. So I always tell people, exercise keeps your body healthy, keeps your mind healthy, and that's just as important. We see a lot of patients come to cardiologists thinking there's something wrong with their heart, and find out it's actually probably just anxiety. And so I tell them in turn, all right, now go exercise. I know it's good for your heart. I know it's good for your mind, good for your body. So exercise is key. You just have to find a way to incorporate it. And these days it's harder, people be inside more, but I'll tell you what, people are clever. Like, I have so many patients, I had a patient yesterday who's like, you know what, me and my twin sister, we exercise, we do a Zoom together and we exercise together. So yes, they're physically not together, but they're exercising. What's one of the most common purchases over the last year? A Peloton bike, right? What's good about that? Yeah, it's nice you have this convenient bike in your home so you don't have to go to the gym, but people are doing classes together all across the country, and it's really great when I hear families saying they're doing this together with their loved ones, maybe across the country, maintaining their physical well-being, enjoying that socialization, which is very important too. So, and even, I loved at the beginning pandemic, walking outside and seeing all these people walking, exercising. More people were outside at the beginning of the pandemic because there was, hated being inside. So that's such a refreshing thing to see. So get outside, exercise. It's great for your overall health.
Great advice, Dr. Gould.
And I would say that sedentary life is the new smoking, right? Smoking was one of the leading modifiable cause of death in this country now, obesity and the sedentary lifestyle. So another thing that exploded in the senior population, you see those little foot pedals that I forgot, the QV or whatever they're called. So I tell them there's no excuse. You can put that in front of your favorite lazy chair, and when a commercial comes on, get the pedaling. So anyone could do that, and that's something they can do with their feet or put it up on the table and start doing it with their hands. There was something I wanted to backtrack on what Dr. Gould was mentioning about blood pressure. When you go see your primary physician, take your blood pressure monitor with you so that when they check it, you can check it right behind them with your blood pressure monitor. That way you can know that your machine is working, one, and two, that you can trust your home readings. There are a lot of patients that blood pressure just shoots up because they're so nervous or they're driving in DC and coming to the doctor's office and their blood pressure is elevated. So take your blood pressure monitor with you at least once.
Great advice. Thank you. Thank you both, Dr. Gould and Dr. Robinson. I think those are really good recommendations. I personally speaking, I know being less sedentary is a goal of mine, just being more proactive and actually physically active. So now that even though it's cold outside, I'll, do my little kettlebell weights, or I'll like walk in place, or just take even a 10-minute break to just go for a walk. I can attest to the fact that it's very helpful in clearing your mind and helping you and helping your heart stay strong. So great advice. Thank you very much to you both. Along with diet and exercise, Dr. Gishlagi, are there any other lifestyle changes that are critical for reducing the risk of heart disease?
Sure. Dr. Robinson mentioned about one of the most important one, like smoking cigarettes. Tobacco use in general is the leading preventable cause of disease, disability, and death in the United States. Smoking and smokeless tobacco, such as chewing tobacco, increases the risk for all-cause death and heart disease. Even secondhand smoke is also a cause of heart disease, stroke, and other heart conditions. Almost 1/3 of heart-related deaths are attributable to smoking and exposure to secondhand smoke. Even low levels of smoking cigarettes increase risk of heart attacks. Thus, reducing the number of cigarettes per day does not totally eliminate the risk. These days, we are dealing with different types of products as well. Electronic nicotine delivery systems, or known as e-cigarettes or vaping, are different and new class of tobacco products that emit aerosol containing of fine and ultra fine particulates, nicotine, and toxic gases. They're all increase at the risk for heart and lung disease. So cigarette smoking plays a key role in heart conditions and heart disease, including coronary artery disease. It's highly recommended to quit smoking with behavioral modification, some replacement with the nicotine products out there, or there are some other treatments available out there if there's a need for help. So some medicines are out there that your healthcare provider can help you prescribe them for you just to quit smoking as soon as possible. Alcohol consumption might be a risk as well. There is some evidence out there that moderate amounts of alcohol consumption can be protective for your heart and may raise the good cholesterol or HDL cholesterol. There are some researches out there that, especially about red wine, says that the antioxidant in red wine can just lower down bad cholesterol, or may raise the good cholesterol and protect your heart. But what you need to know is you don't need to drink too much alcohol to raise your good cholesterol. Exercise per se, as Dr. Gould mentioned, that can boost your good cholesterol. And also there are some other foods out there that you can just get good antioxidants from them, like vegetables, as Dr. Robinson mentioned, fruits and colorful vegetables and fruits, and grape juice as well. So anyway, whether or not moderate drinking alcohol is good for your heart is open to debate. For most people, actually, it does not appear to be harmful, but the key word is moderate consumption. You should limit that to moderate consumption. However, there are some certain people with some certain heart conditions out there, like rhythm abnormalities or heart failure, that even this amount of alcohol consumption is toxic for them and it's not recommended. Heavy drinking, on the other hand, is linked to a number of poor health outcomes, including heart conditions. Excessive alcohol intake can lead to high blood pressure, heart failure, heart rhythm problems, and stroke. So it's not recommended to drink heavily at all. And people with heart conditions should avoid alcohol consumption.
Great, thank you, Dr. Gishlagi.
Can I piggyback? I just love talking, as you can see.
That's why we're here.
My seniors always ask me, should I start drinking? I say, no, don't start at 80. If they've never had a drink before, they want to go out and drink. But I always like to share my my personal stories with cigarette smoking. And Dr. Kaslagi mentioned that my mother died at 49 from smoking from lung cancer, and my sister just had an amputation. And when I tell people that, they look at me, right? And they don't know that smoking is the second leading cause of amputation behind diabetes. And many of our patients that smoke also have diabetes. So the likelihood of you having an amputation, having gangrene, peripheral, what we call poor circulation, but we're going to call it peripheral arterial disease, increases fourfold if you smoke and have diabetes. So some of the symptoms that you might have for peripheral arterial disease, if you're a smoker or diabetic, if you're walking and you start getting cramping in your calf muscle, or if you get heaviness in your legs when you walk at a certain, you can always calculate it. Oh, when I get a block or half a block, my legs get heavy, or I get cramps in my legs. That's, you know, that's something that should be evaluated. If you have diabetes and a smoker, you should go in and take your shoes off anytime you go in to see your primary doctor so they can feel your pulse, right? They can't feel your pulse through your shoes or long stockings all the way up. So if you've never had your toes or your blood pressure, not your blood pressure, just palpating the top of your feet and behind your ankle to check your pulse in your feet as a diabetic and a smoker, you need to have that done.
Thank you very much. Thanks for adding that, Dr. Robinson. At this time, I want to talk to Dr. Akinyele about other factors that we need to consider besides behavioral factors. So how do race and ethnicity factor into the risk for heart disease? And are there any different recommendations or screenings based on those risk factors?
Thanks, Michelle. So I wanted to piggyback on two questions. One about the diet and exercise. So I always tell my patients, like Dr. Gould said, if your ins are more than your outs, there's no way you're going to lose weight. Okay, so a practical way that I tell my patients is to track their calories. There are lots of apps right now. One of them is MyFitnessPal. It's a free app. You can put in what you're eating in the day and see how much calories you're putting. A lot of people say, oh, I don't eat that much. I just eat 2 meals a day, but that 2 meals alone is 3,000 calories. If you're doing that and you're not exercising and losing 3,000 calories, then you're going to keep on putting on weight. So one of the big things is to track your calories and see how much you're putting in and how does that compare to the exercise you're doing. And then the exercise doesn't need to be extreme. Some people have stairs in their house. Go up and down those stairs 10 times a day. Okay, you can use what you have at your disposal. If you work in a building that has stairs, use the stairs instead of the elevator. Go up and down those 3 flights of stairs to get to your building, use those flight of stairs every single day. That's a level of physical activity that you can do. And we particularly as healthcare providers that have long hours and say, okay, I don't have time to exercise, you can do a lot of walking in the hospital alone. And so we can get that in our exercise in that way. And then to tackle your question, how do race and ethnicity factor into the risk for heart disease? So multiple studies have shown that people of color, Black, Hispanic, people have higher rates of high blood pressure, all these risk factors we're talking about, high blood pressure, diabetes, obesity. What does that equate to? If you have a higher risk of having all of those comorbidities for heart disease, then you have a higher risk for heart disease. We've also found out that they have a higher death rate when it comes to, when compared to Caucasians and non-Hispanic and non-Hispanic Blacks and Hispanic populations, that we have a higher risk of death, either because those risk factors are not being addressed like they should, all the things that we're talking about today, or when they do happen, we're not seeking care early enough. We're not recognizing those signs early enough to address it early enough. So yes, there is a race and there is an ethnicity risk for heart disease that we need to address. Does that mean that the screening is different for us versus everybody else? No, it just means that we need to do our part in making sure we advocate for ourselves. A yearly visit to a primary care doctor tells you whether you have high blood pressure, tells you whether you have diabetes, tells you whether you have high cholesterol. When you're put on those medications to lower your blood pressure and treat all those numbers, taking those medications, if you have issues, side effects from those medications, don't just stop them. Have a conversation with your providers as to how you can adjust those medications to make sure that you are getting the best benefit and reducing your risk of heart disease as much as possible from those things.
Thank you very much.
And also piggyback on just in terms of race and ethnicity, there's a certain regions, especially in Southeast Asia, that have higher risk of heart disease, coronary disease. So, race disparities are definitely very important, ethnicity disparities. But the key thing is the underlying theme. You got to see your doctor. You got to earlier recognition, earlier intervention is a way to prevent these things. So that's the key thing. And we do the same risk scores for regardless of the population, where you come from. And a lot of times your family history will tell a little bit of that too, which is why we focus on family history a lot as well.
And when we look at race and ethnicity, I'm going to piggyback and add a little something. When you think about the traditional risk factors we always talk about, heart disease has been a leading cause of death since the last pandemic in 1918, right? So we've been talking about this for over 100 years or more. That's because that's at the peak of the pyramid. At the base of that pyramid, we have something called health equity and social determinants of health that have a huge impact on how someone lives. When you think about social determinants of health, that's how people live, pray, eat, work, become educated. And those factors have a huge impact on overall cardiovascular health. And when you think about zip code dictates how long you live. If you go to someone across Northwest DC across the park, they probably have a 20 to 30 year age difference from 80 to 90 years of age of life expectancy versus someone in Southeast DC that may have a 60 to 70 year life expectancy. So we have to focus on it. We have a panel of physicians, but we also have to have a panel with faith-based organizers, politicians to look at legislations talking about vaping issues, how we look at policing, how we look at environmental influences on overall health. Whether you live in an environment where the air quality is terrible, you live, your asthma precipitates a lot more. You can't go out and go for a walk like I could in my neighborhood if you're scared that you might get robbed, right? So we take things for granted, and we have to look at the overall picture on how social determinants impact overall health as well.
Thank you very much to you all for sharing that. I think those are really, really important points. I want to turn back to Dr. Akinyele. One other question relating back to your comment about the signs and the symptoms. What are those symptoms of heart disease that patients should not ignore?
So I think Dr. Gould brought this up during a prior question when he was talking about exercise. If you are having symptoms of chest pain, chest discomfort, chest tightness, and for women, it could be even more atypical, where you're just feeling more short of breath than usual during an exercise that's usual for you. So I like to give people a sense of, tell me what you were doing 6 months ago and compare it to now, and tell me what you're not able to do. A lot of people are attributed to age, but age going from 60 to 61 should really cause you to start having shortness of breath going up those flight of stairs that you were doing 3 weeks ago. And so if you're having symptoms of chest tightness, discomfort, shortness of breath when you're exercising, especially in particular when you're exercising, those are very worrisome signs that need to be addressed. We don't like for you to wait for you to start having those symptoms when you're at rest. If you're already having it when you're exerting yourself, you should be talking to a provider. You can start with your primary care doctor if you would like, but we are happy to see you as cardiologists to try to figure that out a little bit more. The other symptom that we don't think about is sudden episodes of passing out. So we're focused a lot on coronary artery disease, and that's what most of these risk factors we're talking about are. But there are rhythm problems that people can have. There's heart failure that people can have that can cause you to pass out for no clear reason. So if you're having those kind of symptoms, those are not symptoms you should just brush off and not seek care for. Sudden episodes of passing out should be followed up and investigated as to what the underlying reason for that is, because those are important.
Thank you. Dr. Gould, I have a question about when should patients make an appointment with their doctor versus going to the emergency room?
Well, patients should make an appointment with a doctor on a regular basis, regardless of symptoms. As we talked about earlier, education, screening are very important when it comes to anything in medicine, but especially heart disease, all the stuff we've already talked about. But even, seeing your doctor regularly. I mean, yes, during this pandemic, a lot of people either been avoiding the doctor, avoiding hospitals. I mean, I was even talking with one of my colleagues who's an oncologist the other day, and he was saying he's seen so much more advanced cancer presenting these days because people are not doing their regular colon cancer screening, mammograms, things like that. So it's important to see your doctor regularly as recommended. You can go on the internet and see what, are the recommendations for all those things. But as long as you're following up with your primary care physician, it's important to have that primary care physician. They're so important. They're bread and butter of medicine. They're the path with which they screen patients. And then if someone needs to see a cardiologist, needs to see an oncologist, they're the ones who make those referrals. But it's very important to have a good long-term relationship with your physician. And then in terms of when to go to the emergency room, well, if you think you're having really bad symptoms, I'm having crushing chest pain, oh my God, I have this impending sense of doom. I feel like I'm having a stroke. My face is asymmetric, slurred speech. I have some weakness in one part of my body. Especially if you think you're having a heart attack, stroke, call 911. Don't drive yourself to the hospital. Call 911 and get yourself to the hospital, because as we say in cardiology, time is muscle. The longer you wait to present with a heart attack, the more likely you're going to have heart damage, heart muscle damage. Same thing with stroke. If you don't present within the first hour or two within a stroke, if you do, there's more likelihood we can treat you effectively and prevent complications from that stroke. I mean, stroke is a leading cause of disability in the United States, so it's important that if you think you have those symptoms, you need to go to the emergency room right away. And please, we were talking about this earlier, Dr. Robinson brought this up before we came on live. It's important to go to emergency room, and don't be afraid to go to emergency room, even during this pandemic. I often tell my patients, I think the emergency room hospital is almost one of the safest places during this pandemic, because everyone gets tested to see if they have COVID. So we know who has COVID or who doesn't. You go to the grocery store, you don't know if the person next to you has COVID or not, so it is safe. We as healthcare workers, especially those on the front lines, God bless our nurses, our emergency room physicians, our intensive care doctors who have really been on the front line taking care of every patient, whether you have COVID or not, in the hospital, but also figuring out who has COVID, who doesn't, and safely taking care of those patients has been absolutely remarkable. So I thank all those people who have done that all along the way. And yes, do not be afraid to go to the hospital if you think you have a real emergency. Even if you have crushing abdominal pain, you think, oh my God, my appendix is going to rupture, get to the hospital.
Thank you, Dr. Gould. Dr. Gishlagi, just following along the lines of what Dr. Gould said, what do you say to patients who are hesitant to either go to their primary care doctor or even to go to the emergency room? What do you say to those who are hesitant about the importance of not delaying care?
Sure. As Dr. Gold mentioned, the people should not be afraid of, going to ER or hospitals to seek medical attention, even just maintaining their communication with primary doctors or cardiologists is a key. Even it's more important during the pandemic time. Heart disease still remains the #1 killer in this country. And having underlying heart conditions may put you at higher risk for COVID-19, complications. So you should address, your underlying heart conditions first. Even if a person just contracts COVID-19 infection, they might be at higher risk for dying from this virus if they have underlying heart conditions. As Dr. Gould mentioned, time is muscle. And it's very important to report to, ER and hospitals should you get any symptoms, including, chest pain or chest discomfort, shortness of breath, or any pain that goes to the other areas like jaw, back, or down the arm. So you never know that it might be just a heart attack. If you delay your heart attack, as Dr. Gould mentioned, that time is muscle. You're going to lose your muscle. The long-term consequences of delaying care is a lot. and you cannot, compensate for that. So it's really, really crucial and important. There's some study from American College of Cardiology that they showed that the death rates and complications from people with, underlying heart conditions is about 10.4% when they contract COVID-19 infection, while the death rate and the risks for general population is about 0.4%. So it's very crucial just not to delay care. And our ERs are very safe place to be, as Dr. Gold mentioned. All of our first line providers are vaccinated. Everybody just gets tested for that. The ER culture is different than before. Like the ER is not crowded with a lot of COVID patients or infected patients. So patients would be just isolated. All of the patients can be just tested. Everybody is using the personal protective equipments. So ER is the safest place to report. And even if you're scared of going to your doctor's offices, there are some options these days as well. If you do not have an active problem and just you would like to follow up with your cardiologist or other providers, that you can just set a virtual appointment, audio video virtual appointment, and it's available for your providers and cardiologists that they have sit like in their office or home, and you're at home, and you can just check your health with them and just address the main issues and problems before something bad happens during this pandemic. So again, I reemphasize, Dr. Gold, again, do not be afraid to go to ER. Do not be afraid to maintain your communication with your primary doctor or go to your doctor's offices.
Thank you very much, Dr. Gishlagi. I think that's a very important message. We have a few more questions. I know we're getting toward the end of our broadcast, but I'd like to get through a few of our audience questions. So thank you very much for tuning in and sharing those with us. I have a question from Elizabeth, who's asking, how does Hunter's syndrome affect heart development? Anyone who would be able to take a stab at that question?
I don't think I can't take a stab at that one. It's probably more for a congenital cardiologist. I'm not versed in that.
Okay, no problem. Thanks, Elizabeth, for sharing that. We'll try to answer that offline and get back to you for your question. I have another one from Sharon, who's asking, if your calcium score is 100 and the LDL is over the limit and HDL is really good, is a statin necessary?
So I think risk stratifying this patient by calculating the 10-year risk of coronary artery disease or lifetime risk matters as well. You can just include that one in addition to elevated coronary artery calcium score. So less than 100 is kind of a mild risk, but again, it doesn't mean that the patient is not at higher risk. So we have to include other risk stratifiers. I think one of the good one is just to calculating the 10-year risk in the office based on age, gender, blood pressure, cholesterol levels, and add that. If the 10-year risk is greater than 7.5%, definitely it's recommended to start statin therapy in addition to higher level of calcium score, as well as the LDL or bad cholesterol is elevated.
Yeah, I think that's a good question. And, it kind of goes along the point of what we sort of describe as shared decision-making with our patients. There's no set numbers, no set patient profile. But that's why it's important to sit down with your physician, whether it's your primary care doctor or your cardiologist, to talk about that. In certain patients, I would say, yes, that you should be on a statin. In certain patients, maybe not, but, there's other things we can do to talk with that patient, address their concerns. I always talk with my patients and I like to make a decision. They always want, what do you say? What do you recommend? And we do make recommendations, but there's an art to medicine. It's not just all science. There's a lot of science behind the recommendations we make, but there's an art to making a shared decision with our patients based on their concerns, what their risk profiles, what their family is, what their other comorbidities are. So it's hard to give a direct answer just based on numbers, but that's why it's important to have a good relationship with your physician.
And there's one thing that you might see after starting a statin. So I don't necessarily recommend getting a repeat coronary calcium score, since if you're already on the statin, you're already getting treatment, that you might see a higher calcium score. Now you might have some of that soft plaque that now has been stabilized and becomes hard. And the next time you do a calcium score, the calcium score is higher. So what do you do with that? Right. So I wouldn't necessarily suggest getting repeat calcium scores if you already have, if you're on treatment. So.
All right. We have another question. Thank you all for sharing your responses with us. I have another one from Michelle. This goes back to something that we did elaborate on earlier in the broadcast, but Michelle was asking, how can you lower your blood pressure, I guess, to get it to a regular or normal level? How can you regulate your blood pressure levels?
Well, we talked about lifestyle changes earlier, and if your blood pressure is high enough, you need medication, and people often think, oh, I need medicine or lifestyle changes. No, it's actually both. We talked about exercise, limiting the amount of salt in your diet, losing weight, treating sleep apnea. Those are all kind of lifestyle modifications that should be a part of the treatment process. But usually if your blood pressures are high enough, you're going to need medications in addition to those lifestyle changes. So, once again, getting back to the whole point of talking with your physician, earlier recognition, and achieving those lifestyle. I mean, it's been a common theme we talked about throughout this whole talk about all the different lifestyle modifications you can make to help prevent anything with heart disease, whether it's heart failure, coronary disease, hypertension. So that's all very important. Exercise, exercise, exercise. And, all those other things we mentioned, but also, people think that's a failure in their health that they're taking medication. It's not. We're talking about primary prevention, and hypertension being a silent killer. If you don't recognize and don't treat it, you can develop renal failure from untreated hypertension. You can develop dissections. You can develop, heart failure, as mentioned earlier. So if you recognize it and treat it, you can avoid any of those complications.
Yeah.
I would also like to emphasize that treating or going on medicines doesn't mean you've treated it. And it has to be that your goal is at the optimal goal to reduce your risk of having heart disease. If you're on blood pressure medicines and doing all the lifestyle things and your blood pressures are still 150s, we're still not where we need to be. So we need to reduce your risk as much as possible on those therapies that we're recommending. So just going on medicine is not the only answer, but making sure that you and your physician are working in conjunction to make sure that those levels or your risk is being lowered is very important.
Yeah, I think that's a great point, Dr. Akinelli, because to be honest with you, what studies show that those people who are being treated for hypertension, only about 50% of them are actually at goal. So we, as we're not doing our job in terms of getting our patients to the numbers they want to be. Sometimes it's a compliance issue and so forth, but it's important to get those numbers down to where we want them to be so that we can be more effective, right, in preventing any of those complications.
I would like to emphasize on monitoring the blood pressure at home as well. It's really important, because, when the patients present to the offices, it's just one numbers, and we cannot judge based on one numbers. And it's very important that the patients monitor the blood pressure appropriately at home within a long period of time, just to make sure that we achieve that goal at home.
And one of the easier things to do is to write a prescription. It's a two-way street. The patient has to take responsibility and in the care as well. So if we're given the medication that we can't realize, like, well, why is it that the blood pressure is not being controlled? Then you see that same patient in the hospital taking the same medications and they're well controlled. Then you have to look at other things, what's happening in the patient's life, in that person's life outside of the office or outside of the hospital. What are they doing? Are they eating certain ways? Is there a stressful environment? Are they using their CPAP mask consistently? So the patient has to be a part of that treatment regimen.
Absolutely. Well, thank you all very much. I have a few more to get through, so bear with me. I have one other question from Viola, who says, I'm following the keto and Mediterranean plans with intermittent fasting, and they've been doing well. She's asking, what exercises and supplements do you recommend? I walk, but probably need more strength exercise. I've lost 30 pounds since June. So we have an active patient. They're, being proactive, as you all mentioned, is good to do, but are there any other steps that they should take?
I mean, I applaud her for being proactive, exercising. That is something I forgot to mention when we're talking about the exercising segment. Aerobic exercise is very important, but also strength training also should be in addition to that. So helping build muscle, obviously, the more muscle you have, the more fat and calories you'll burn. So strength training, resistance training, in addition to your aerobic activity, is very important. As cardiologists, I think you generally tend to recommend the Mediterranean diet, or as I refer, pesco Mediterranean diet, fish, vegetables, as discussed earlier. The keto diet, you got to be careful in terms of having eating really fatty foods. We recommend avoiding fat, especially trans fats. So, and then when you talk about weight loss, back to my original statement, there's no diet that works. It's more of exercise, burning more calories, and being smart. Everything in moderation. All the things we've already talked about. And intermittent fasting does work. That's, breakfast. Why they call it breakfast? You're breaking your fast. So it's part of what we sleep. You're supposed to get, I don't know if we've mentioned this enough, at least 6 to 8 hours of sleep. So you want to get plenty of sleep at night, and treating things like sleep apnea, because the more sleep you get, the more calories you will burn, which will also help you lose some weight. So that's just as important as well.
Thank you. I have another question from Gomri, who asks, what do you recommend for someone who is experiencing irregular heart rhythms?
So definitely should actually see their primary providers or a cardiologist to obtain EKG in the office, just to figure it out further about the irregular heart rhythm. Atrial fibrillation rhythm or flutter is a rhythm that is common. So if the patient feels that the heart rhythm is irregular, should seek medical attention, because it puts people at higher risk to get a stroke. And it's very important to diagnose it early on and try to treat it with medicine, and try to actually change the rhythm back to normal if possible, to just maintain the normal rhythm. It's really important to figure this out further. And as I mentioned about the alcohol consumption, people with underlying rhythm problems should avoid alcohol consumption, because even a small amount of alcohol may prone them just to develop abnormal heart rhythm.
And it depends on the patient as well, starting with the primary care physician first. So there are multiple, skip beats or palpitations could be just that. And one of the things I always say is that once you start noticing them, you start noticing them, right? So a lot of people will notice these skip beats when it's quiet at night, when they're laying down. And once they feel it, they get more nervous, and then that precipitates more. That could be a whole host of things. You're not sleeping well. Dr. Gislagi mentioned alcohol. If you have obstructive sleep apnea, if your thyroid's out of control, if your electrolytes are out of whack, if you're dehydrated, if you have a stressful day, how frequent are they happening? If you'll look at someone that's 22 years of age versus 80 years of age, and look at it somewhat different when you're thinking about someone that's coming in with palpitations. And palpitations is just an umbrella terminology for any time you feel your heart. It could be skip beats versus fast beats. And we can't tell that unless we capture it, whether it's an EKG or an extended monitor that you wear for several days to really predict that. So starting with your primary doc, getting your basic lab work done, whether it's your thyroid, your electrolytes, and assessing it from that standpoint first.
Thank you. I have one last audience question for today. I think it's a really good one. So this is what Gil is saying. As a 5-time heart survivor, my issue is I recognize that the symptoms, she recognizes the symptoms, but still is not taken seriously, even at the hospital. there seems to be nothing that rectifies this issue in women. What would you suggest for her?
Did you say Gail?
Yes. Yeah.
Okay, I probably know her. Um, I would say, if it's the same person, being the best advocate that you are. You wouldn't go into a grocery store, any of the store, and have someone treat you in a specific way that you didn't like, right? You have options to go elsewhere. Healthcare is not free. Sometimes it's harder for others to find adequate healthcare. If you have a concierge practice versus a clinic setting, that's quite different. But be your best advocate and continue. You know your body better than anyone else, and pressure the docs like, hey, this is something different. I think I need to get better evaluated or more evaluation.
Absolutely. I think that's a really good, important point that anyone can take, no matter if you have heart disease or, maybe a family history of it. I know I have a family history of it. So it is top of mind, one of those conditions that's top of mind for me. So really good piece of advice to be your best advocate when it comes to maintaining good health. Before we go, I'd like to ask the panel entirely, you guys, whoever would like to share, is there anything else, any other last message that you would like to share for our audience today?
I think that's something that we haven't yet addressed is pregnancy and women in particular, women in heart disease. Recognizing that things like gestational diabetes and gestational hypertension, preeclampsia, eclampsia, things that happen around pregnancy do increase your risk for heart disease in the long term. So they're not things to be taken lightly. And there's a lot more knowledge about that. And we're incorporating a lot into our cardiovascular practices all across the board to make sure that your OBGYN history is also taken into account. But if your doctor is not doing that, it's definitely something to bring up and to recognize that those things do have implications, can have implications for you in the future. So definitely keep an eye out for that and to make sure that, like we've all said, your routine, at least yearly visit with a primary care doctor, as well as advocating for yourself in the future and making sure your heart health is the best it can be.
I would like to emphasize also that, this COVID-19 pandemic, again, one more time, don't be afraid to go to ER or hospitals should you develop any symptoms or any problems. So please seek medical attention without having any fear of contracting COVID-19 infection. Also, please maintain a good communication with your primary doctor, your cardiologist, with the regular, checkups and addressing your underlying heart conditions to stay healthy and safe and reduce your cardiovascular risks.
Yeah, and just to kind of reiterate that, it's a team approach. You as an individual patient need to take responsibility for the things you're doing in terms of seeing your doctor, and obviously the lifestyle changes that you can make. In addition to, addressing your prevention. And prevention is the key, and seeing your doctor and working with your doctor, that, approach as a team with that communication and figuring out what is the right thing for you, what is the right medicine for you, what's the right test for you. And as you develop more relationship with your clinicians, you'll find that hopefully we can prevent more heart disease from happening.
And 70 to 80% of the things we discuss can be modified. So it's not all doom and gloom. I like to tell people it's about TLC, not tender loving care, but total lifestyle change. And we talked about all these things. It's total, not just one thing, over here, another thing over there, but it's a total life on how you stress, how you eat, how active you are, how you interact with other people, and trying to help modify and help bring that risk down.
Well said, everyone. Thank you very much. I think those are all great important points that we all can take with us after today. So that wraps up our broadcast. Thanks again to Dr. Akinyele, Dr. Gishlagi, Dr. Gould, and Dr. Robinson for joining us today and sharing your expertise and great advice. Thank you so much to all of you, our viewers, for tuning in and sharing your questions with us. For more information or to schedule an appointment, please visit the link in the comments section. We will share that briefly. And thanks everyone. We'll see you next time. Bye.